Okay, good afternoon, everyone. I'd like to welcome all members and guests to the October 2nd, 2024 Board of Health meeting and remind everyone our meetings are web streamed and televised. If you could take a moment to ensure your phones are on silent, that would be great. With that, I'll call the October 2nd, 2024 Board of Health meeting to order, and we have a handful of Board of Health members not in attendance today, but we do have quorum. So Councillor Michele, or Board Member Michele, Huffman, Van Andrieschie, and Duthie have sent their regrets. All other members are present. I'm looking for a motion to approve the agenda. Moved by Board Member Brunton, seconded by Board Member Columbus. All in favor? Carried. Are there any declarations of pecuniary interest today? Seeing none. We have no consent items and we have no registered deputations. So we'll go right into our presentations today, and I will turn it over to Sarah Page to introduce that.
Good afternoon, everyone. I'd just like to introduce our Acting Medical Officer of Health, Dr. Malcolm Locke, for a little update, and you do have a handout in front of you that he'll be referencing.
Yes, good afternoon, and it's a pleasure to be here. And I have a few items that I think the board should be aware of, and I believe you have a handout there. This year, particularly of concern is the fact that we've already entered the respiratory virus phase that comes around every year. And this year is a little bit different because we have three things of note that are going to be circulating already. One is SARS, COVID-19. One is a respiratory syncytial virus, and of course we've got influenza coming through as well. So we have three significant viruses that could come through, and they could come through at the same time, which would be somewhat concerning. With regards to COVID, we've had a positive number of cases in Ontario recently, and this is basically across the US. We've had about the percent product positivity remains fairly high throughout the states, but recently has been tending lower, so that's a good sign. Influenza, currently the percent positivity is somewhat low, but we're still seeing sporadic cases. There is a particular strain of influenza coming through this year, H5N1, that you may have heard of. It's avian flu, and its normal host is in birds, and it's transmitted from birds to mammals. And at the moment, there's quite a surge in activity in the cattle areas in the United States. One concern about this, of course, is if that virus mutates and then it becomes human-to-human transmissible, we really don't have any vaccines or anything specifically that we can counter any outbreak that takes place. With regards to vaccines, currently, there's a table there that I've included at the bottom of when these immunizations are going to be available. This has just been released by the ministry a few days ago. So we're looking to try to encourage people to take as many of these vaccines as we can, because this is the only protection that we really have, building up people's immunity to these vaccine preventive illnesses. And antiviral medications, people think are an alternative, but they're really not. We use those, we can't use those continually, so we can't use them as a prophylaxis, and we can only use them when people are already infected. So my thing is that I'm going to be encouraging as many people as they can to get their flu shots as soon as they can, and to follow the guidelines that are being put out by the Ministry of Health. We've had also some other viral activity circulating. There's been a case of Eastern equine encephalitis, which is an unusual virus, but it's a nasty virus, and its name implies that horses are involved in this, and although they can be involved, other mammals can be involved with this as well. It's a mosquito-borne and transmitted disease, and is quite serious if we get it, because as a viral entity, it gives some inflammation in the brain, which is very difficult for us in a clinical area to try to change and to control. Since January 2024, there's been 166 confirmed cases of EEV noted in Ontario, and 86% of those were male, 2.5 were female. As far as the monkeypox is concerned, another virus that's circulating that I'm sure you've seen in the media, there's been a lot of activity in Africa with this virus. And for those of you that are interested in learning a little bit more about it, there's a link there on the internet to an article that was written in the Toronto Star, which I read, and which summarizes things very well. So it's very good. We've had one unfortunate death from rabies, which also highlights the fact that rabies is still an entity, it's still circulating. And this particular case was contracted in Northern Ontario, but this year, as opposed to previous years, the bats themselves are testing positive, and we've had a 16% positivity rate of tested bats for rabies this year, as opposed to in the less than 10 in previous years. So that's another thing that we're trying to make the public aware of, that if they become if they have any communication with bats at all, or wake up with a bat in their room, then they should seek advice. Unfortunately, the case that we had here, it was a child, and basically they woke up with a bat in a room. The parents looked at the child, didn't see any signs of a bite or scratches or saliva, and didn't seek getting the rabies vaccine. So unfortunately, that child is now deceased. Nearly all the cases that we've had result in death. So it's extremely important that people that have any form of exposure seek the proper medical attention. Thank you, Madam Chair. That's all I have. If anyone has any questions, I'd be pleased to try to deal with them.
Thanks, Dr. Locke. Board Member Columbus.
Yes, thanks, Dr. Locke. And what is the, you mentioned shot, I guess, but what is the treatment for rabies?
For rabies?
Yeah.
Well, there's an there are two approaches to this. The first is an immune globulin. Immune globulins are used as a short-term response for giving people immunity that is from pooled plasma. So the idea is that in the pooled plasma there will be antibodies that can take effect immediately, but it's only a very short period of time. And the second thing is we back that up with a rabies vaccine program, which then promotes the individual to develop their own immunity. So it's that two-step. The first immunoglobulin has to be given within 2 days of exposure in order to be effective.
Is that the one where you get a shot in the abdomen?
It used to be, but we can give those shots now. It doesn't necessarily have to be in the abdomen, but yes, it's a series of shots that are given over a period of time.
Thank you.
Any other questions? Okay, thank you for your presentation. Mover and a seconder to receive the presentation as information. Moved by Board Member Brunton, seconded by Board Member Van Passen. All in favor? Carried. Moving along to the Board of Health meeting minutes, we have item 8.1, which is the July 3rd, 2024 meeting minutes. I'm looking for a motion to approve the minutes as presented. Moved by Board Member Columbus, seconded by Board Member Berry. All in favor? That is carried. There are no items of communication on the agenda, so we'll move along to 10, which is staff reports and discussion items. 10.1, Healthy Babies, Healthy Children Program and Funding. Over to Ms. Page.
Thank you, and through the chair to committee, I'd like to introduce Program Manager Nikki Loss for Healthy Babies, Healthy Children, and Substance Use.
Thank you, and through the chair to the Board of Health Committee, I will be presenting HSS-24-041, Healthy Babies, Healthy Children. To start, just a brief overview of what I'll be discussing today, excuse me, is some information on adverse childhood experiences and overview on the HBHC program, the 2023 stats from our program, funding update, and the funding proposal. So I know I'm here today to give you an update on the HBHC program and on the funding we received from the ministry. However, before I begin, I wanted to share some information on what adverse childhood experiences are and why understanding what they are and how to prevent them are fundamental to the work that we do in our Healthy Babies, Healthy Children program. So adverse childhood experiences refer to traumatic events that occur during childhood, and they include abuse, food insecurity, household dysfunction, to name a few. These experiences can significantly impact a child's physical, emotional, and social development, often leading to long-term health issues and behavioral challenges. Research around ACEs demonstrates the connection between early trauma and later in life health outcomes, emphasizing the importance of prevention and intervention to promote resilience and healing. So as a child's brain develops, it is crucial to prevent trauma. The more events experienced, the more damage to the child's developing brain. Long-term, this can present as risky behavior, mental illness, substance use, and chronic disease. If we look at risky behavior, for an example, people who have experienced ACEs may engage in risky behaviors for several reasons. So coping mechanism, risky behaviors can serve as a way to cope with emotional pain, trauma, or stress. Engaging in these behaviors may help to alleviate or relieve or give them a sense of control. It also affects their decision-making. They can impact the brain development, particularly in the areas of impulse control and decision-making, and this can lead to impulsivity and difficulty weighing the consequences of actions. Desensitization. So experiencing trauma can lead to a desensitization of risk. So people might become accustomed to danger or chaos, making risky behaviors seem more normalized and less intimidating. Social influences. So those with ACEs find themselves in environments or peer groups that maybe reinforce those risky behaviors, and then also making it more difficult for those people to break that cycle. Low self-esteem. So ACEs can negatively impact self-worth, leading to individuals to seek validation or acceptance through risky behaviors, even if they know the risks involved. Mental health issues. So ACEs are linked to higher rates of mental health conditions such as anxiety, depression, PTSD, which can contribute to engaging in risky behaviors as a form of self-medication or coping and a means of escape. If we look at chronic disease and how a child who experiences trauma may be at greater risk of developing chronic disease later in life, when a child's brain is developing, the cells, a trauma can affect the way the cells replicate and duplicate, which can lead to cancer in children and in later as adults. In addition, it can affect the way their heart functions by increasing their blood pressure and leading to hypertension and heart disease. The cost of ACEs in North America is around $745 billion. No Ontario or Haldeman Norfolk costs is there data specifically related to Haldeman and Norfolk in Ontario, but we're planning on looking at how we can better track ACEs and their impacts locally. By equipping my nurses and ultimately our community with the knowledge around prevention and mitigation of ACEs, we can improve overall health and decrease the overall economic burden of adverse childhood experiences. So in summary, the overall summary from our Healthy Babies, Healthy Children program is that it's designed to help children in Ontario have a healthy start in life, provide them with opportunities to reach their full potential, and it began in 1998 and was mandated by the Ontario Public Health Standards. The program is funded by the Ministry of Children, Community and Social Services and is delivered through our HBHC team. Our team consists of a program assistant, 4.5 public health nurses, and 4 family home visitors. Our program works by providing effective upstream interventions focusing on stronger families and stronger, more connected communities, addressing systemic and structural determinants of health and improving health equity. Our team delivers HBHC in collaboration with community partners such as NGH, family health teams, child and protective services, REACH, just to name a few. There's a lot of research that speaks to the strength of the HBHC program. In the Chief Medical Officers of Health's annual report of 2023, they identified that HBHC as an effective and promising substance use intervention through its ability to connect and build stronger families. So just sharing some stats as I have in the report. In 2023, 1,060 children were born in Haldimand and Norfolk. Of those born, we received 993 screens. From here, 775 families were identified with risk, and that means 2 or more yeses on the ministry-developed universal screening tool. My team was able to contact 623 of those families and offer a home visit. 145 families received an in-depth assessment during their home visit. And an in-depth assessment is just that. It's very in-depth, asks many questions from their family history, parenting strategies, mental health, relationships, etc. You may be wondering why there's such a big gap between our contacts at 623 families down to those that consent to a home visit. So the universal screening that's created by the ministry, it's great as it captures more people at risk than may be captured with focused screening or assessments. However, once we connect with them, we may find out that based on the screening questions at the time, they're no longer an issue. Like mom has had a C-section and a larger baby, if they've got a history of smoking and didn't have a high school education, or they have anxiety but supports in place, or lastly, it's voluntary, and even if they are at high risk, they can say no to our program. After completing their in-depth assessment, 96 families were confirmed with risk and consented to receiving the home visiting program. Throughout 2023, my team interacted with families 4,343 times and in total supported 623 families. These interactions were anywhere from home visiting to provision of resources and connection with community supports. So even if a family doesn't meet the criteria for our program, my nurses ensure they're set up for the best possible outcomes and are aware of the community supports that are available to them. They also know that they can come back and reach out to our program if something presents later on. We also have designated nurses to go to our local hospital every day, Monday to Friday, and engage with clients directly. This accounts for an additional 185 interactions in 2023. In addition to the work that they do with clients every day, my staff are also responsible for completing annual training, internal and external committees, and providing support to other community partners as requested. While the numbers highlight the quantitative impact of our program, it's the feedback from families and the positive outcomes they experience that truly showcase its value. The 3 success letters included in your package are just a glimpse of the wonderful testimonials we receive from our clients. So for the first time since 2015, the Ministry of Children, Community and Social Services has provided a funding increase to HBHC programs across the province. We are hoping to use this funding to hire a 0.5 FTE public health nurse. So our rationale for hiring the staff is because the growing population and evolving health needs in our community have prompted many of our community partners to expand their services. NGH has a full-time OB and will be adding 2 more in the coming months. Additionally, the Haldimand and Norfolk family health teams have enhanced the services available to their perinatal care clinics. We, like our community partners, must step up to meet the increasing demands and ensure everyone in our community receives the care they need. Families who have had babies, especially those born in larger community hospitals, are being discharged at 24 hours. This increases the needs of our clients as the first 3 days are crucial and vital in supporting breastfeeding and maternal mental health. Norfolk County has lost their only full-time pediatrician, and Haldimand County doesn't have one who practices locally. With just a few walk-in clinics available and a shortage of family doctors in Haldimand and Norfolk, we're now seeing patients who either don't have a family doctor or can't get timely appointments for medical care. Over 60% of our clients are dealing with mental health concerns, which my staff are actively supporting and addressing through various interventions. To meet the growing needs health needs, particularly in mental health, we have a lot of work ahead. We aim to adopt a more proactive approach and framework to better respond and prevent adverse childhood experiences. This additional 0.5 FTE will be dedicated to leading efforts on adverse childhood experiences, both within HNHU and the broader community. The role will encompass training on brain development and ACE prevention. They will participate in the provincial ACEs community of practice to ensure approach aligns with efforts across the province. Additionally, they will support team members with evidence-based strategies to mitigate the negative impacts of impaired parenting practices, postpartum depression, and other mental health concerns. This includes working to reduce the negative health impacts our clients face due to social determinants of health barriers. As part of our ACEs work, we'll focus on strengthening our relationships and collaborations with the Indigenous communities and neighbors, as well as our low German Mennonite population. If we think back to the stats I just shared, if only 50% of those was screened with risk accept our program, my nurses would be drowning, as they are visiting as many as possible right now and are relying heavily on our family home visitors. The additional FTE will also align our team structure with that of our future partner in public health, Brant County Health Unit. By aligning now, we aim to minimize the potential changes in service delivery and to our community and staff. Pardon me. In summary, hiring an additional 0.5 FTE will enable my team to address the needs of our communities more effectively, work that we continuously challenge to keep up with. Given the priority of addressing ACEs without additional support, we risk being unable to comprehensively mitigate and prevent their negative impacts on our community. Thank you for your time. I'm happy to answer any questions you may have.
Any questions? Board Member Columbus, then Van Passen.
Thank you, Madam Mayor. How do the Haldimand Norfolk statistics that in the chart stack up to other Board of Health jurisdictions?
So it's difficult to compare to different health units depending on their population, but if we compare to Brant County Health Unit, we're very similar. In some areas we have done more promotional work or more work about engaging with our prenatal clients versus they have done more in their early childhood. So it's pretty comparable. We're reaching the same, roughly the same percentage of people.
So we're pretty well rural. Any comparison with urban areas, like strictly urban health units?
I'm sorry, unfortunately, I can't speak to that. So the ministry sets out targets, and we are meeting or almost meeting those targets on a biannual basis. They track and we meet with them to discuss.
Because you mentioned 60% have mental health issues, and I just wondered if that's similar right across Ontario.
Yeah, I'm not sure. I can say in communication, because I'm involved with some working groups around perinatal mental health, the health units that are on that working group, we're all seeing a rise, so we're doing more work around that.
Okay, thank you.
Board Member Van Passen.
Yes, thank you, Madam Chair. The screening tool you use for that, is that a provincial document?
Yes.
I need to question how accurate it is if you do 993 screening and the tool shows there's a need to follow up, but only less than 10% of them actually need it. So I wonder if we need to talk to the province about changing the screening tool itself, or maybe, as Member Columbus pointed out, maybe it's more geared to an urban environment and we're more rural and it just doesn't fit down here. But is it something that you could follow up with the province and see if there's any need for changes to the tool itself?
Yes, thank you. Sorry, through Madam Chair to the board member. So there was discussion. It's been some time since they've revisited the screening tool. At the last discussion, the screening tool was used to encompass and try to attract as many people to make sure that nobody was missed. So at the last meeting, which was just under a year ago, this time last year, there was discussion, but at the time they weren't offering to do any revisions. So the questions aren't specific to rural community. I can share the screening tool with you. A lot of it, like I spoke to in the presentation, is if you've had a history of mental illness or if you have a history of smoking, what's your level of education? So those are very general questions that can capture more people, but don't necessarily mean that they have a risk related to bringing their baby home or there is evidence that speaks that level of education is correlated with mental health and maternal health concerns, so that's why that's on the screen. But then after talking with them, that's not an impact or a negative impact on the way that they parent or their mental health.
Just from what you said there, I'm glad you didn't have it when our kids were young, because I failed every one of those already, and my kids turned out rather well, I think. But
I think that when the screen, the universal, like most universal screenings, when they're created, they're trying to capture as many people, and that's why there's 2 or more of those. They try to capture as many people as possible, and then through our assessments, because the screening tool is difficult to ask individual focused questions, so from there, then it's the responsibility of my team to get more in-depth information and to determine if there's actually a risk there or not.
Any other questions? Just for clarity, so it's the first time there's been a funding increase since 2015. That's year-over-year funding?
So this is a one-time funding.
One-time funding, so that's why the levy impact is noted?
Mm-hmm.
Okay. All right, there's a staff recommendation before you. That staff report HSS 24041 Healthy Babies, Healthy Children Program and funding update be received as information, and that the Ministry of Children, Community and Social Service-based funding increase of $60,745 be endorsed and accepted by the Board of Health, and further that the budget amendment be approved as outlined in the report, including a base FTE increase of 0.5 for the Healthy Babies, Healthy Children Program. Mover and a seconder. Moved by Board Member Columbus, seconded by Board Member Berry. Any discussion? Debate? All in favor? That is carried. Item 10.2, Youth Approach to Youth Substance Use Prevention, HSS 24035. Ms. Page?
Thank you, Madam Chair, and I'd just like to introduce our Program Manager for Planning and Evaluation, Jackie Wood, and her team members today, the health promoters, Josh Daly and Lena Hassan, to present this report.
Good afternoon. My name is Lena Hassan. I'm a health promoter at the Haldeman Norfolk Health Unit, and Josh Daly is also a health promoter, and we're on the planning and evaluation team. We're here today to introduce you to an evidence-based youth substance use prevention model called Planet Youth. Before we get into our discussion of Planet Youth, we would like to give you a brief overview of what is currently known regarding youth substance use. It is important to remember that there is no one single cause of problematic substance use among youth. The drivers of substance use are complex and include a mixture of biological, environmental, and social factors. Substance use is influenced by genetics, early life experiences, example trauma, and ACEs, adverse childhood experiences that Nikki just mentioned, family history of mental health or substance use, as well as factors such as the marketing of psychoactive substances, their availability, family and peer relationships, and social determinants of health, such as stable housing and family income. The presence of risk and protective factors, which Josh will explain a little later on, can lead one towards or protect one from substance use. Research also shows that the earlier the age of first substance use is associated with progression towards heavy substance use and increased risk of substance use disorders. That is why much of the focus of public health is on delaying initiation and preventing harms from substance use. We also know that youth report a variety of reasons to explain why they use substances. Substance use is different for everyone and exists on a spectrum with varying stages of benefits and harms, where a person moves back and forth between the stages over time. Finally, we know that substance use is a complex issue requiring a complex solution. It requires investing upstream to ensure people have equitable access to social determinants of health and mental health supports, as well as strong relationships and social connections that can protect them from harmful substance use. Locally, based on the 2022 Canadian Community Needs Assessment, evidence showed that there was an uptick in substance use compared to pre-pandemic levels, with participants reporting the increased use of alcohol being the highest at 17%, and 7% for both cannabis and tobacco use. We will now take a brief high-level look at what youth substance use looks like in Ontario. Because we are a rural health unit with a small population and there is a high cost to oversample in a provincial survey, we do not have access to local and timely local data, but instead we rely on provincial data. Based on the 2023 Ontario Student Drug Use and Health Survey, the most commonly used drugs among students in grades 7 to 12 are alcohol at 35.6%, prescription opioid pain relievers at 21.8%, cannabis at 17.6%, and vapes or electronic cigarettes at 13.4%. We also know that cannabis and alcohol use increases with grade level. Cannabis use ranges from 12% of students in 9th and 10th grade, and it goes up to 34% of students in 12th grade, while alcohol ranges from 8% in 7th and 8th grade. It goes up to 30% in 9th and 10th grade, and finally, by grade 12, they're at 54% of students. 10% of students in grades 7 to 12 also report binge drinking, which is defined as 5 or more drinks on one occasion at least once in the past month. Also, about 1 in 8 or 13% of students in grades 7 to 12 report vaping an electronic cigarette in the past year. When looking at early initiation of substance use, we see that a substantial proportion of students who currently use a substance reported first using that substance before grade 9, with alcohol being the highest at 47%, followed by vaping at 43%, tobacco at 29%, and cannabis at 18%. The substance use team at the health unit have worked hard to establish a local community drug and alcohol strategy for our region, which is an evidence-based and comprehensive approach to addressing substance use. Titled the Lighthouse Community Strategy, the plan is structured around the 4 pillars of prevention, treatment, harm reduction, and community safety. We envision that Planet Youth will fit under the prevention pillar, where the focus is on interventions that seek to prevent or delay the onset of substance use and that address root causes of substance use. I will now pass it to my colleague Josh to explain a bit more about the Planet Youth model.
All right, thank you, Lena. So when we speak about Planet Youth or the Icelandic prevention model, what we're speaking about, it's an upstream evidence-based approach to prevent substance use and improve outcomes for youth. The approach has been shown to not only improve substance use outcomes, but also overall well-being for youth as well. And the approach is a bit different from some other models or approaches in that it sees society as the patient. So historically, public health has done a lot of interventions where we speak to young people as an individual, telling them about the risks or harms associated with substance use. But we know that youth are really social beings, they're products of their environment. So this moves a bit more upstream and looks at what are those root causes for the substance use and how can we look at the risk factors, how can we mitigate those risk factors and strengthen the protective factors to reduce that overall risk. It really is rooted in community action, collaboration, and data-informed decisions, and we'll speak a little bit about the data later. So you might be asking, why Iceland? In the mid to late 90s, Iceland had a bit of an issue with substance use. They were actually the highest rates of substance use across Europe, and they came together, a group of social researchers and community agencies, to figure out what can we do to tackle this problem. So they came up with this approach, the Icelandic prevention model, and over the next 15 or so years, they saw a fairly sharp decline in their substance use rates, as seen in the chart here. And then equally as impressive, they've been able to sustain and maintain those gains over the past 10 plus years as well. Not surprisingly, countries around the world took notice of this once it became public, because substance use it's a universal concern. Lots of countries are struggling with this. So they wanted to see, how did Iceland do this? Is there a way that we could replicate or borrow some of their approaches to see similar success? So that's what Planet Youth is. It's the organization that actually exported the approach and supports other countries and communities to replicate this in their own community. So speaking about the risk and protective factors, They might be familiar to you already, but in a general sense, risk factors are any characteristic of an individual, a society, a peer group that puts them at a greater risk of negative health outcomes. On the flip side of that, protective factors are things that act as a buffer. They kind of protect them from experiencing those greater levels of risk or experimenting with risky behaviors and substances. So we want to find ways to increase those protective factors, decrease the risk factors to tip the balance in favor of the protective factors. As far as implementation of the Icelandic prevention model locally, similar to any other community-based approach, it looks first at who should be at the table. So it's forming that coalition of community partners that have some interest in positive youth outcomes, bringing them together to talk about a plan, how can we do this? And the data that it gets collected, it's through secondary schools locally, and that gives us a real-time snapshot of what is our situation. Like Lena mentioned, in public health, it's hard to get real-time local data, especially in rural communities. So it's really great that this data that's collected, Planet Youth analyzes it, provides reports in 6 to 8 weeks. So then the community has that recent local data that they can use to come up with these action plans to figure out, which are those highest issue risk factors, what are the existing protective factors that are in place, and what kind of interventions could we do to address those. The survey looks at the 4 key domains that have been identified in a young person's life. So that includes their school life, their family and home life, their peer group, as well as what they do in their leisure time. So there are questions on the survey around all of those domains, as well as substance use behaviors. And then once the results are in the community, they come up with the plan, and then the survey is repeated every 2 years. So they're getting this local data on a regular basis, implementing interventions, and then doing another survey to see, are we making some gains? Do we need to tweak? Do we need to continue on what we're doing? So it really is a long-term approach to substance use. At the start of this year, we were presented with an opportunity to apply for a grant through the Public Health Agency of Canada. And so we did that, and then in spring, we found out that we were successful in receiving these funds. We were one of 7 sites across Canada to be granted this funding. So the funds are earmarked for communities that are really at the initial stages of this. So it's looking at community engagement, capacity building, getting the coalition formed, some training of community partners under the Planet Youth model. So that's what we've been working on as well. There is an opportunity for sites that had received the Stream 1 funding that they will be likely approached in 2025 for Stream 2 of funding, which would be for the actual data collection, intervention, implementation phase of Planet Youth. So we're optimistic and kind of looking ahead to think that we'll have an opportunity to apply for those funds as well. The funds that we did receive, they're used mostly for staffing toward this approach. There is a contract that you enter with Planet Youth as they provide some project management and support along the way, as well as the work with community engagement. As you'll see, we'll be doing a community forum coming up later in the fall. You'll likely receive a save the date or an invite to that. We'd love to have everyone there. It'll be for community partners, parents, anyone that would like to be involved and learn more about this and how this could look in Haldimand and Norfolk. So we're very excited about that. We'll have some experts from Planet Youth there as well. And then in the meantime, Lena and I will be continuing to meet with various stakeholders from all the different sectors, from faith communities, service clubs, parents, school boards, recreation, leisure opportunities, youth serving agencies, substance use partners, everyone that might have some interest in this. We'd like to introduce them into this and how we can collaborate and really streamline our efforts to benefit our local youth. With that, I'll ask if anyone has questions, and thank you for your time.
Thanks for your presentation. Are there questions? Board Member Columbus.
I just want to say, we all know that substance abuse is an issue in our community, and we got to do more to combat it. But my question is, you've outlined what you're going to do with the Iceland program, but what have we been doing in the past with like through the high school system? What have we been doing in the past to curb this issue?
So through Madam Chair to Board Member Columbus, a lot of our approaches in the past years have been on campaigns or collaborating on events and initiatives, kind of more short-term or one-off approaches. It's been shown that they have not the impact that we would hope to see. So really this is about moving upstream, looking bigger picture. What are those day-to-day impacts? So if a young person experiences or comes to, sets up a booth that they see at their cafeteria as a point in time, but really looking at their whole experience as a young person. What are they doing in their evenings? What are they doing as a family unit with their social crowd? So it's a bit more comprehensive and holistic than what's been approached in the past.
But I take it we have had staff from the health unit go into schools to discuss this subject, right? How
yes, we
often have they gone in, like to a high school or even, I noticed grade 7 here, public school, to address this problem of alcohol, tobacco, and drugs?
So through the chair, we have a school health team that has school health nurses that work with the principals to identify what are the greatest concerns in their schools, and they come up with plans and they use the best options or programs available currently. So there are things that they're doing around vaping. That's one of the concerns that's been noted a lot in our elementary schools. So there are some initiatives that they're doing, and we're not saying that those need to stop or that they're problematic at all. It's just that while that's happening, we need to also be kind of moving upstream to stem that tide before it becomes a greater problem.
So I guess we're just hoping that the Planet Youth program works better than what we've had in the past. Thanks.
Yeah, we have to, yes, as public health, we look at what the evidence shows as the most effective approach, and this is kind of what's happening around other health units and around the world, that looking at those root causes upstream approaches is the way to go.
Board Member Brenton.
Thank you, Madam Mayor. Mike, can you go back to this slide where it shows the age groups and the alcohol use, the cigarettes and so forth? Yep, there we are. My question on that is, those aren't Norfolk County stats, are they? No, where are they from? Or where were they gathered from?
Through the chair to the councillor. So these are from Ontario Student Drug Use and Health Survey. So it's at a provincial level.
Okay.
Because we are a rural health unit with a small population, we might have one or possibly two schools that get surveyed. So it's not overly representative. So that's
Okay.
why we don't have local data.
I guess that's my concern here. Like, if we looked at those stats only applicable to Norfolk, it might be significantly different. Is that safe to say?
It could look different if we have our own data. It could look different than this provincial one because it's not overly representative of what our region looks like.
Right. Is there any way, like you say they may have looked at 2 schools in Norfolk. The province did that.
Yes.
Is there any way we could get that data?
Yes, this is the data. This was from 2023, so it's the longest running school health survey. It comes out every 2 years.
No, I meant, can we get that data for Norfolk, the 2 schools? Let's say they did 2 schools. Can we get that data, or is it just all bundled into one?
Yeah, it's bundled into one, and you could probably look at it, but it wouldn't be overly representative. So even if you looked at just trying to look at just the Norfolk schools, it might be 1 or 2 schools, so it wouldn't be that representative.
Okay. All right, my last question is, and I see you've asked for a 0.5 person, am I correct? Or how did I read that? 0.5, we've got a 0.5 in the last one report, and did I not see a 0.5 in this?
Sorry, through the chair, no, there's no,
No.
well, you can speak, sorry, yes, this is, Sorry, I'll let Jackie, our manager, speak to that.
Yes, through the chair to the board member, there was a temporary one-time, part of that was a temporary position. So we've used that, no impact on the levy, to backfill some of the work that Josh and Lena were doing. We felt it was important that it's not a new person coming in, that it's an experienced staff member that can continue it on. But while Josh and Lena are focusing on that, this was to backfill some of the work that they were, the other work that they were, had on their plate at that time.
Okay, thank you.
Councillor Van Passen, do you have a comment? Or board member,
Yes,
sorry?
thank you, Madam Chair. This is one of these charts that is, I guess I'll be generous and say totally useless. I'm going to read the title. It says Youth Substance Use in Ontario. Alcohol, 47%. But that's not what it is. It is the percentage of secondary students who used the drug in the past year reporting their first use before grade 9. Well, it could be that less than 1% of the secondary school students actually used alcohol, but 47% of that 1% who used alcohol also used it once before grade 9. So what is the point of putting this chart in here? It means nothing. It gives a false sense of what is going on out there. So is it trying to sway public opinion because most people don't read the fine print? But what's the point of having it here? It means nothing.
Through the chair to the councillor. So as mentioned, the intention of showing this chart is because we know that research shows the earlier the age of first initiation of substance use, the progression to heavy substance use, and further on when they're adults, they have substance use disorders. So that's why the focus of public health is on delaying initiation and preventing harms. So this is one of the indicators that the OSDUS, the Ontario Student Drug Use and Health Survey, they survey students to say, when was your first use? When did you first start using alcohol and all these different substances? Because as I mentioned, the research shows that if they initiated before grade 9, these are the research shows that they will have a progression towards heavy substance use and substance use disorder. So we're trying to ensure that we delay initiation. So that's why we track these ages at the first initiation. Thank you.
Well, I don't like getting in debates like this, but I don't have much formal education. I'm just, the backwoods farmer in Norfolk County, but I don't think I needed to do a study to figure out that the younger you are when you start using it, the more you used and the more often you use it ends up in a worse situation. I didn't have to study that. I could figure that out all by myself. But what I'm saying here with this chart is that it's presenting a false sense of what it's supposed to be presenting. Most people will look at that chart and say, oh, youth substance use in Ontario, 40% alcohol, 47% alcohol, 43% cigarette, 29% tobacco, 18% cannabis. But that's not what this chart is presenting. It's presenting that people who in the past year used alcohol at least once, the first time, 47% of those people did it for the first time before they started high school. So it's giving a false impression here, and I don't think that's fair to put out public documents that give out false impressions like this.
If I could
Sure.
just add through the
Please,
chair.
Josh.
So this chart is used in conjunction with the previous slide, which you'll see here, which says that 35.6% of the students in grades 7 to 12 used alcohol. So then after that fact, then we said of those users, this is the percent that started prior to grade 9. It's not used in isolation, I understand. Yes, the title of the chart reflects what the bar graphs are demonstrating there.
Okay, are there any other questions? None? I'd just like to thank staff for seeking out a grant and applying for it and being successful. That's great. Thank you. With that, we have a recommendation before us that report HSS 24035 be received as information, and further that the Board of Health endorse the implementation of the Icelandic prevention model as a local strategy to reduce youth substance use. Moved by. A question?
Like, I have no, I mean, I guess I'm willing to try anything, but I'm wondering if we go through this exercise, if we can, I don't want to see that chart that Councillor Van Passen, I tend to agree with him that it's really not reflective of what's going on here in Norfolk County. That's my concern right now. And I guess when we're done, if we could get some indication of Norfolk County. Now, I'm sure a lot of that information, I'm sure Toronto's got a lot worse problem than we have, or some of the bigger cities, but I certainly would like to see, if we get through this exercise, what it has done for Norfolk County and Haldeman County, or our new health board, whatever. Okay, thank
Jackie,
you.
do you want to provide a comment?
Yes, I'd like to comment on that. Through the chair to the board member, that's why we have this, we're so excited about Planet Youth. There's this unique opportunity that we do get that local level data from our high schools. And the plan with Planet Youth is to collect that data every 2 years over a series of years. So we'll have real local data 6 to 8 weeks after we collect it, so we can make some decisions. So that's why one of the reasons why we're so excited about this grant opportunity.
Okay. Board Member Brunton moves, seconded by Board Member Van Passen. Any discussion or debate? All in favor? That's carried. Thank you, staff. Okay, we're moving along. We have no bylaws, no motions, notice of motions. I don't see any printed. Does any member of the Board of Health have any other business they wish to raise? Any staff? Oh, please, go ahead.
Thanks, Madam Chair. I would just like to bring to the attention of Board of Health that we are asking you to block October 30th from 10 a.m. till noon in your calendars right now for a special Board of Health pertaining to the merger. It will be a closed session as well. We will provide further information down the line. Thanks.
30th.
October 30th, 10 a.m.
And with that, we have the confirming bylaw. So I'm looking for a mover and a seconder for a motion to approve the confirming bylaw for today's meeting. Board Member Columbus moves bylaw 2024-9BH, being a bylaw to confirm the proceedings of the Board of Health for the Haldeman Norfolk Health Unit at this regular Board of Health meeting held on the 2nd day of October 2024 be read and passed with, signed by the chair, the clerk, and affixed with the corporate seal, seconded by Board Member Van Passen. All in favor? That's carried, and I need a mover and a seconder for adjournment. Board Member Brunton moves for 1:53 p.m. adjournment, seconded by Board Member Columbus. All in favor? Carried. Thanks, everyone, very much. We'll be back for public hearings.